Hello, Dr. Arif. How are you today?
Good. How are you, Freddie? I'm
Good,
good.
good. Cannot complain. It's a great day.
Uh, Nice way to start your weekend.
Right. Yes.
I'm lying. It's not. Not the funnest way.
Oh, if we're learning something, I think it's a great start of the weekend.
So, what are you a medical student?
No, I'm a pre-medical student right now.
Pre-med student. Okay.
Yes, at the University of Maryland.
University of Maryland.
So I'm
University.
gonna start us off now. So good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Arif. Dr. Arif completed her residency in internal medicine from St. Joseph Hospital in Chicago, Illinois. She then went on to complete a fellowship in nephrology and hypertension from Loyola University and Medical Center in Maywood, Illinois. She currently serves as a nephrologist affiliated with the Texas Health Arlington Memorial Hospital. And now it is my honor to request Dr. Arif to begin today's session. Thank you.
Good morning, everybody. Thank you, Freddie, for the beautiful intro. You pretty much said what I want to say about me is that yes, I am double board certified internal medicine and nephrology and hypertension, and this is going to be a nephrology talk. Just for the record, so how we're going to do this is I'm trying to see there's a chat box in here. So if you guys have questions as we talk, feel free to share them on the chat box. But in the end, we can do the raise your hand and then we can take one-on-one questions. It is a little bit, I'm trying to gauge interest. Are you all medical students or pre-medical students? I just share in the chat box. I'm just curious to know because that way I will keep my language as layman as possible. Pre-medical. So we have two pre-meds. Okay. I guess I'm waiting for more people to join. We just have a few more. We have Arsha and we have Marshall. Um, so okay, that really helps. So yes, my journey to nephrology was, I want to say, very interesting as to why I choose nephrology. So I actually grew up in Dubai. Well, let's start a little bit about me, right? I grew up in Dubai, and I went for my medical school. I went back home where my parents are from, and that was Pakistan. And I did my graduation, and then I moved to US after I got married. And 2010 I graduated. In 2012 I had applied for the match, and I matched in internal medicine in Chicago. And during my residency, I knew I loved a lot of acute medicine and internal medicine, but I just wasn't the person who would, and I loved more of like the critical care part of it. And so, but I wasn't so committed to being an intensivist. So I wanted that critical care, I wanted that acute medicine without being a hospitalist or a critical care medicine, if that makes sense. And so this, I found nephrology to be the best of both worlds. So I could practice a lot of critical care, I could practice a lot of general medicine, and kind of have what I really want to practice in medicine. So that's the beauty of nephrology. And I went on forward with doing nephrology fellowship from Loyola University. 2016, I graduated in 2018, and since then I've been in private practice. Now, the downside of nephrology, because now that you guys are potentially going into medicine, and I won't call it as a downside, but if you want to look at it, most of your medicine fields are hospital setting, and then you have clinics, right? So you are doing both for the most part, majority of them. In nephrology, you're doing like a third thing, which is dialysis. So you're doing hospital, you're doing clinics, and then you're doing dialysis, not on a daily basis, but on a frequent basis, at least twice or thrice a week. So that adds to like your workday burden. But is it doable? Hell yeah. Don't let, if you're interested in nephrology, don't let that, I mean, people are going to talk to you about it. Oh my God, it's so cumbersome and all that, but don't let that deter you from pursuing nephrology. I think it's a beautiful field. It makes you an amazing internist. It makes you smart. The most common saying about nephrology in fellowship is that kidneys are smarter than the smartest brains. And basically, you get the point, right? So the kidneys there's a brain, there's a human brain, and then there's a kidney brain. And so kidneys try to outsmart your brain. So it's actually a very interesting field. Okay, let's go. Hold on. I'm trying to get this chat box out of the way from my screen. Okay, let's get into the presentation. What is hyponatremia? Is my first question. Anybody who's ready to jump in with an answer? What do you get from it? I have pre-meds, and that's okay to be wrong, and it's okay to be wrong. Low sodium, Freddie. Okay, one more. Somebody else.
Oh, Dr. Arif, sorry to interrupt, but we can only see your first slide still. So if you could maybe try to switch like your presentation view or something, because we can only see the first slide, or we can take over.
Oh, can you see now?
No, it's still the first slide.
Really? How is that possible? What about now?
Oh yes, now it's changing. So you can go to the next slide.
But it's not the full view. What about now?
No, it's just the first slide.
Yeah. So the only way you're seeing it is if I don't put you in it. I mean, this is okay. We can probably just go ahead and do it this way.
Yeah, that's no problem. Yeah.
Okay.
Perfect.
All right. So where's my chat box now? So I had low sodium in the blood. So I have, okay, so that's the answer I'm getting. So that is one take-home message I want you to know and understand from this particular talk is that it is not a sodium problem. I know it says, this is what the word terminology says, it's a low sodium, but it's actually not. I wish they had a better term for it, like aquanemia or something, because it's actually a water problem. So, okay, yeah, it is a water problem. And if that's something the only thing you can remember from today's talk is this. That's all I want. That's all I want you to take home and remember. And that's how you're also going to be able to treat your patients and diagnose your patients by understanding the fact that it's actually a water problem. So it's either too much water or too less water, which is causing this issue. It's usually defined when your serum sodium is below 135, and it's a very common disorder. So if you're going to go ahead and practice medicine, you are going to see that it is very extremely common in hospital medicine. You're going to see a lot of patients coming in. So it's something you have to deal with on a day-to-day basis. So to kind of dwell into this further, let's talk a little bit about physiology of water distribution. I want to make it a full screen for you guys. Are you guys able to see the chat? Everybody? Are you guys able to see the slides? Anyone? Amna? Yes. Okay, perfect. So, so water is the most abundant constituent in the human body. It makes up about 50% of your body weight in women and about 60% of your body weight in men. And if you guys remember from your physiology classes, we have your extracellular fluid and your intracellular fluid. And so your intracellular fluid, we all understand, is basically fluid in your cells, makes about 75%, and then you have your extracellular fluid, which makes about roughly 25 to 45% of your body weight. Now, the reason why this is important to know is for you to understand. Jacqueline is saying yes, but not full screen. Okay. Well, as long as the slides being changed, I think that should be okay. So your extracellular fluid is what we're working on. Is what is our is a space where the sodium is being an issue. So your extracellular fluid is further divided into your intravascular space, which is your plasma water, and your extravascular space, which is the interstitial space. And this extravascular space, you know what's interesting is that even I'm not able to change the screen when I'm on there. We'll just stick to this. Sorry about that, guys. So this extracellular space is where the sodium is being, where you have sodium as your main and main cation. So and the majority of your particles in your extracellular fluid space is sodium, and it has some accompanying anions, chloride and bicarbonate, whereas in your intracellular fluid space, it's mostly your potassium and the other organic phosphate esters. And now that you know that which compartment has which important cation and anion, let's talk about osmolality and tonicity, because we're going to use this term a lot in today's talk. Osmolality is the solute or particle concentration of a fluid. So in layman terms, it really is reflecting that how much solute you have in a particular compartment, right? You take a glass full of water, a bucket full of water, and you put salt in it. That's the amount of salt relative to that water in that bucket is your osmolality, is your concentration of that particular molecule in that particular compartment. So that's basically what osmolality is telling you about. Anybody has any questions regarding osmolality, or if you haven't been able to understand, feel free to raise your hand. Because if once you understand what osmolality is, then we can go ahead and talk about what is the disorder and what is sodium disorder and what are we dealing with, how does it become a disorder. Now, again, I think I forgot to highlight in this slide is that your human body has a certain set osmolality, which is roughly between 270 to 295, 275 to 295 milliosmoles per kilogram. So that is where our plasma osmolality has to stay, or our extracellular fluid space osmolality has to stay. And so the goal is to kind of regulate your entire hemostasis accordingly, right? And anytime this osmolality changes, the concentration of this solute, which is, we're talking about sodium, changes in that space, that's when all these other factors, and like Freddie mentioned, ADH comes to play a role. So a sodium disorder, again, disorders of sodium concentration are caused by abnormalities in water hemostasis, leading to changes in the relative ratio of sodium to body water. Water intake and circulating ADH are the two important key regulators. Okay, so the most important thing which is regulating is that osmolality I just mentioned is 275 to, it's a different kind of margin in every textbook, but roughly 275 to 295, around that range. These are the two key regulators, and we're going to talk about that in detail. Now, what is ADH? Anybody? I think you recently had you had a talk last week or a week so ago, and she's actually also a good friend of mine, and she mentioned that she had discussed the physiology of nephrons with you guys, and so we're going to go a little bit off again over a few of those things. So ADH is your antidiuretic hormone, and it is released by your hypothalamus. It acts on, if you guys remember the loop of Henle, the ascending and the descending limb, and I'll go over some of those diagrams. It acts on your receptors in your thick ascending limb and your collecting duct. So you have V2 receptors in your thick ascending limb and your collecting duct, and it inserts these little channels on those on your nephron, and the goal is to not diurese. Basically, the word diuresis means the getting rid of water and some electrolytes from your body. That's the word diuresis, right? And that's what we do when we urinate or when the body makes urine. But Antidiuretic hormone's job is to not let that happen. So what it's doing is it's causing these little aquaporin are absorbing more water and trying to make the urine a little bit more concentrated. And yes, so the goal is actually 280 to 295. Yeah, roughly. And that's the goal, is that so the ADH is released by the hypothalamus to kind of keep your human body osmolality in that range. Now, there are two signals for your ADH to be released. There are two main signals of why your ADH is being released by your hypothalamus. For any reason, let's you have an increased plasma osmolality. For example, you go to a Chinese restaurant and you eat this amazing, I don't know what, Chinese dish which has a lot of salt in it. And the next thing is you come home and you're drinking water and you're drinking water and you're drinking water. You have an increased thirst because your plasma osmolality increased because you just put in a lot of salt in your body, remember? And that is going to trigger your ADH. That there's too much salt, it's too concentrated, you know, and that ADH is going to start going to your kidneys and your tubules and going to start holding on to that, holding on to the what do you call it, water for you, and so that normalizes your osmolality. And same thing, plasma volume. Anytime you're losing plasma volume, for example, you're exercising and you're sweating, and so you lose a lot of water, right? Just by losing water, you're going to have a trigger to release your ADH, so you can have that water retention and you can kind of bring your plasma osmolality back to what it should be. And so this is that little diagram, what you were just talking about, right? So anytime you're dehydrated, when we're talking about sweating, dehydrated from not eating, vomiting, diarrhea, right? All of those things, your body's on the drier side, your plasma osmolality is going to increase, which is going to trigger your hypothalamus and those osmoreceptors to do two things. Release ADH, right? We just talked about it, and that's going to cause antidiuresis. And the other thing is thirst. Remember, I talked about how you're also drinking a lot of water anytime you have salty food, and that water intake. And both of these factors are going to increase your body water and normalize your plasma osmolality, just decrease your plasma. And the minute it decreases, it itself has there's like this. It signals to stop the production of ADH and stop your thirst mechanism. So it's all working in this loop. Any questions so far? All right, so you guys are pretty pro about ADH at this point. All right, so I have a little tubule picture again, just for revision purposes too, and we'll go ahead and kind of enlarge the screen right here for you all. So you remember from your last nephrology lecture, so we have your proximal tubule, your glomerulus, your loop of Henle, your ascending loop of Henle, your distal comminuted tubule, and then this is your diluting segment, which is your collecting duct. Now, the goal, this is where your urine is being formed, right? So all of these micro collecting ducts collect and eventually meet up in the renal pelvis, and then that's where your ureters are originating, right? So urine is being formed in this nephron. And so something important to know is that this entire segment is your diluting segment. And what does that mean? Is that in the ascending limb, you're basically absorbing all your salts. You're absorbing your sodium, your electrolytes. And so the urine which is passing through this distal convoluted tubule is very dilute. So it's a very dilute urine. So it has more water and less solute in it. And then when it comes to this part, which is your collecting duct, this is where mostly your ADH is acting. Now, based on what your body's osmolality is, your thirst mechanism, or what state your body is in, right? Depending on what you need, is how much ADH is being released. So that's probably going to decide how much water they need to retain versus how much urine they need to make. Like, for instance, if you have excessive water intake, you're not going to have that. That's going to shut down your ADH production because the goal is to get rid of water. But if you're on the dry side, you're having salty food, you're going to have a lot more ADH sitting around. So, and those aquaporins, so they can absorb as much water and make the urine more concentrated. So, again, so all of this is normal, right? But what happens in hyponatremia, there's an abnormality, right? Something is not working. Either the ADH is not working, that signal is not being stopped, something is off. And that's the whole point of understanding all of this. Is then we talk about how ADH is not working and what's going on with hyponatremia. So hyponatremia generally broadly can be classified into 3 different big types. And it also depends on the tonicity of your serum. So how or the osmolality of your serum. They're interchangeable terms. And so we'll talk. I'll have a pictorial diagram for that too. But briefly, I want you to remember this: the hypotonic hyponatremia. So remember what we talked about, right? When that you have to have your serum osmolality at a certain range. When your serum osmolality drops below the lower limit, which is, let's say, 275 or 280, that's your hypotonic hyponatremia. And your isotonic hyponatremia is basically your serum osmolality is still in that same range of 275 to 290 range. Your serum osmolality still is in that same range, but your sodium is low. And what's really happening at that point is you have other substances which is basically causing that sodium to be low, like lipids or proteins. And sometimes at some point it used to be a lab error, not anymore these days. We have better lab testing techniques, but really isotonic hyponatremia needs no further workup or treatment for the sodium. You treat the protein, like a paraproteinemia. You treat the lipids if that's the reason. So you don't really treat the sodium, you're treating the root cause of that hyponatremia. And then there is hypertonic hyponatremia, in which your serum osmolality is higher than that normal limit. And that's because besides sodium, there are some other osmoles which are adding to the osmolality of it and relatively diluting your sodium out. Sodium is not diluted out, but because there's a lot of glucose, and you will see this very commonly in your diabetic ketoacidosis patients, your DKA patients. And this is also termed as pseudo-hyponatremia, which is a falsely low sodium. The sodium is not really low, it's just a false low sodium, but it's really happening because that little container, remember we talked about a bucket of water and we had salt in it, but now it has a lot of sugar in it. So that sugar in that bucket of water is increasing the osmolality, right? Kind of relatively diluting, although it was the same amount of sodium in there, but it's diluting that sodium out. And so what you're looking in your lab work is a low sodium. So again, you treat the underlying cause, you treat the glucose, or you treat whatever is causing that, and instead of treating the sodium itself. And then let's talk a little bit more in detail about this main entity right here, which is your hypotonic hyponatremia, because that is what you see in clinical medicine for the majority of the time, and that is what you want to treat. So this is a nice pictorial let's actually kind of zoom into this a little bit. So hyponatremia, we talked about serum osmolality, we just went over your normal and high serum osmolality and all the things that can cause it. And so let's focus right here. So your serum osmolality is low, right? So the next thing, so this is basically true hyponatremia. This is the hyponatremia you want to treat. And the next, obviously we're going to talk about diagnostic testing but the next important thing to look at is the volume status of your patient. And that will classify us and try to determine what kind of hypotonic hyponatremia this is. So if someone is on the dry side and dehydrated and has lost not just like has lost fluid from the body, right? That's hypovolemic. Your patient's looking dry. If the patient's looking, on the drier side. And so common causes dehydration, diarrhea, vomiting, right? Anybody who's on diuretics. So you put these patients on diuretics, maybe it's a little bit too much for their body, and they're all that fluid that is being pulled out of their body is causing them to be dry. And so diuretics, and there are certain nephropathies in cerebral salt wasting syndromes, all of these, and mineralocorticoid deficiency, all of these can create that state where your sodium is low and your total body water is also low. And then you have your euvolemic causes, which is basically your body volume doesn't change. So you're basically looking at a patient who looks pretty well in terms of his volume status. And these are the causes, and we're going to go a little bit briefly over them as we go further too, but the syndrome of inappropriate antidiuretic hormone release, postoperative hyponatremia, hypothyroidism, psychogenic polydipsia, beer potomania, drug reactions, and so forth. And then another big category is your hypervolemic causes. So you have too much water in your body, and that's when you have patients with congestive heart failure, liver failure, renal failure. So mostly your multi-organ failure patients fall into that category, and we're going to go a little bit more and talk about these little categories in detail as we go forward. So again, hypovolemic hyponatremia is basically you're losing both salt and water at the same time. And we went over these causes, sweating, fever, burns, GI losses, all of that. So, and so you're losing, again, salt and water, right? But you're also losing more salt than water, right? So there's like a relatively more loss of salt. So that's why in your human body compartment, you have your sodium is on the lower side, right? And then we had the euvolemic one in which you're basically like your ADH hormone, right? Remember what your ADH hormone does? It is holding on to all that water and salt, but it's holding on to more water rather than salt. So now what's happening is that your body is retaining that water. You have that normal solute content, but because it's retaining more water, it's diluted out. Your salt, which is, the problem is not the salt, the problem is that ADH which is being released, and that's being diluted out. And then your hypervolemic causes we just talked about. Again, there are certain factors, congestive heart failure, your heart's not pumping blood. And what's really happening is because your heart is not pumping, let's say, for example, we'll just go into one example. In congestive heart failure is you have lower blood pressures. These patients have lower arterial blood pressures, right? Because your heart is not having an effective ejection fraction. So the efferent arteriole in your glomerulus, I don't know if you remember, but we could go back on this diagram right here. And right here. So the efferent arteriole, which is bringing in blood, is sensing that the blood pressure is low in the human body. And instead of, obviously kidney cannot outsmart the brain, but it's trying to outsmart the brain, and it's trying to think, okay, maybe this patient's dehydrated. Maybe we don't have enough water, and maybe we don't have, we need to retain more water, right? And so once this is signaling, this low MAPS, low blood pressure, signals the brain to produce more ADH. And so now you have all this ADH sitting around here and these aquaporin, and they start absorbing water. So we're already struggling with a congestive heart failure who's trying to breathe better, and we're trying to get rid of that fluid. But on top of that, you have all this ADH which is sitting around and making the condition worse for you. So it's like this vicious cycle you get into. And then the treatment basically comes in trying to stop that ADH production, or trying to, not really ADH production, you can't stop that, but trying to kind of balance that out. Okay, so going back, and okay, I have a little error here, so I'm gonna fix that. So we're gonna talk about, yes, how is this now sodium presenting, right? So we talked about different types of sodium, talked about the physiology, and now how are these patients presenting and what is it really causing? So you can divide hyponatremia into two different types. You have your acute and you have your chronic. Acute hyponatremia occurs when it occurs like that, boom, boom, boom. Something just went wrong. A patient's clinical condition changed, for instance, developed diarrhea, had nausea, vomiting, or was just doing something, and so there's a quick drop in your sodium, and that quick drop in your sodium causes and that's within so the roughly the duration is 48 hours. A quick drop in your sodium causes fluid shift into your brain cells, and that fluid shift into your brain cells can cause a lot of symptoms, like a lot of symptoms. So your patients can present with headache, lethargy, anorexia, nausea, vomiting, and if that swelling is more than what your brain can handle, it can cause seizures, or confusion, altered mental status, and sometimes rare and worst cases, we've seen one or two of them, your brain actually ends up herniating, and patients go into coma and respiratory failure and even death. And one of the most, I guess, common causes of that, where you still will see that, is called primary polydipsia, where people are drinking way too much water, and you actually see that in marathon runners. So when marathon runners are running, and the people that they have their team just standing by and just handing them bottles of water while they're running, and even though they don't need that much water, but they can be a possibility, and there are chances that you're drinking more water than you actually need to, and that too much water in your body can dilute that sodium out and quickly drop your sodium levels to scary thresholds, like I'm talking from 135 to like 110, and that could drop in your sodium can cause that fluid shift within your brain cells and cause cerebral edema, and unfortunately with the worst outcomes. So, and I've actually seen a patient who are presenting like that. So, that is one entity of how these patients present, the acute ones. And then you have the chronic hyponatremia, where sodium has been low for like a gradually longer time, and this is your congestive heart failure, your CHF, your renal failure patients, right? And what happens is, because your drop was pretty slow, your brain has developed these adaptive mechanisms to equalize the tonicity. So instead of the water shifting in and causing that cerebral edema, it starts excreting these solutes. So there's no like cerebral edema component, right? But on the other hand, these patients have an increased risk of a syndrome called as osmotic demyelination syndrome. I don't know if you've heard of this word, but this is probably one of the most scariest things to ever have to deal with. And it can be actually a lawsuit too for a physician if you were not able to. Well, you can still do everything you can, and sometimes you can still see ODS happening, but there are certain rules or criteria we have to follow when we are trying to take care of these patients who have chronic hyponatremia, because osmotic demyelination syndrome is basically syndrome where these chronic patients, let's say they're sitting in 120s and 115s, and you rapidly correct them and you bring their sodium to 135 or 140, that big jump of sodium being corrected too quickly can cause demyelination of your neurons in your brain and cause permanent brain damage, permanent paraplegia, hemiplegia, permanent like I said, neural damage, and that like I said, it's a pretty scary situation to be in. And the factors which increase your risk, I have a slideshow here. Let's actually go and read through that first. So what do you see here? You see, this is your normal brain with a normal osmolality. And what they're saying is that anytime you have water going into the cells, you water gain, low osmolality, you're quickly going to develop all of these symptoms, right? Acute symptoms, which is basically, and they're trying to show, I know it's not my best slide here, but it's trying to show that there's a lot of swelling and edema, so you can see that sulcine gyri, right? And that's like this rapid form. But in your slow adaptation, what's really happening is you are trying to excrete these solutes, and when you're excreting these solutes, and you're also excreting water with it, acute edema doesn't happen, and so you don't see that swelling. But improper therapy can actually cause demyelination, as opposed to proper therapy, which can obviously keep your brain as is. So so having said that, so what are the factors which can increase the risk of developing osmotic demyelination syndrome? So it's malnutrition, it's liver disease, alcoholism, and really low sodium levels, less than 105. And if you have concomitant potassium, hypokalemia, all of these are risk factors of developing ODS. So the goal of these, so like I said, because it's chronic, you can develop ODS, and your symptoms are very subtle. So you're only going to have symptoms. These patients are really just going to present with like some mild cognitive deficits or gait instability, or they'll just say we're just feeling weak and we're just not feeling ourselves. And because this is chronic, it is very important for us to know that you have to very slowly correct this. So you can't just bring your sodium from 109 to like 135, 140. You have to not correct more than 6 to 8 MEQ milliequivalents in 24 hours. And it just has to be a very slow, gradual correction. If you overcorrect it, you have to bring that sodium back down. It's just a crazy science. And we won't go much into management here. And yeah, that is pretty much. Oh, I think we missed something. That's what I was going to be like. I'm sorry, you guys. I think this whole going back and forth. Yes, we missed. We were going to talk a little bit more about tonicity. I apologize. I was also kind of wondering like what happened. So I think we've been a little back and forth with these slides, and I was too excited showing you guys the nephron again, and I kind of skipped a few slides. So remember this one where we went over the different types of hyponatremia. So we were gonna, the next slide was this. Yeah, we did this. Okay, we skipped the diagnostic testing. Okay, we went into presentation, but let's see. Okay, now you know how these patients are presenting. Actually, maybe this worked better for us, right? So you know sodium, you know how these patients are presenting, and now you're like, what do we do? Okay, so here's a question for you guys. If you guys are still awake, listening and paying attention, what are the key diagnostic tests to determine the type and tailored treatment of hyponatremia? What do you think? Any guesses from anyone? I am waiting in the chat box for your answers. I'll give you guys a few seconds. Any takers? We talked about it. Urinary sodium, good, excellent. What else? We've been talking about it. The first thing I explained. Serum osmolality, you guys. So that's one, right? You need that as like just first prelim test to determine what kind of, and let's go with it, right? So you need that first prelim test. This is your first test to check what you're gonna measure your serum osmolality right there to see if it's a pseudohyponatremia, it's a hypotonic, or it's a hyperosmolar. And then the second most important test is, which is for me, it's like the test I need. I probably don't need serum osmolality. I can probably work without urine sodium with my years of experience. But what I cannot work without is your urine osmolality. It's like it's like the test you need. To determine your treatment and your type of sodium hyponatremia. And so what is urine osmolality? So your urine osmolality, basically, again, remember how we were checking your serum osmolality? So we're taking a sample of your blood and we're checking what the osmolality of your serum was. It's exactly the same thing. You take a sample of your patient's urine and you check the osmolality. And basically you're checking how concentrated is that urine, right? How much solute is in there? How much salt are you wasting or losing in that, right? And answer is pretty arbitrary, obviously, but there's a rough ballpark figure of 100, but it could be, when you're practicing, you kind of gauge how how this is working. But anytime your serum osmolality is more than 100, means just your urine is a little bit more concentrated in the setting of hyponatremia. Now, remember, we're also talking about, so your patient's coming in with hyponatremia, and remember, it's a water problem, right? For the majority of part, it's a water problem. It's too much water, right? It should have been like, I think a better name would have been a hyperaquanemia. I cannot, if I would ever write a book on hyponatremia, I'd probably name it that way. So it's a water problem. It's too much water. And anytime you have a high urine osmolality, now you know that there's ADH sitting there in your urine, also absorbing water, and that is a problem, right? So you have low sodium, which is there, but you also have this ADH, which is absorbing more water, and it's kind of contributing to that low sodium. And similarly, if your urine osmolality is on the lower side, so not similarly, and on the other hand, if your urine osmolality is on the lower side, which basically means your ADH is appropriately absent, and that's what your body needs. It's like your body does not need ADH in the setting of hyponatremia. And that's happening, for example, in cases of primary polydipsia and low solute intake. And I touched base a little bit on primary polydipsia with you guys. So let's go back on this little chart right here and kind of try to work our way. So low urine osmolality. So you're basically making dilute urine. You're not losing, you're trying to keep all that salt. You want to absorb all that salt and just get rid of water, right? And in that low urine osmolality is telling me your ADH is shut down, right? And you see these in patients who have primary polydipsia. We talked about the marathon runner example, beer potamania. These patients are only drinking alcohol. They have no nutrition in them, and tea and toast diet. Again, some in elderly patients, and you see that so commonly. When you're practicing medicine, that they're just literally living on canned foods or some bread and butter. There's no one to cook for them, and so these patients present with this particular, tea and toast diet, and so their sodium and they have low sodium with an appropriately shut down ADH. And then on the other hand, you have patients, which is the bulk again, is your urine and urine sodium. Your osmolality is higher than higher, and that means you have ADH sitting there. And so this increased ADH, now again, remember we went over quickly over the hypovolemia, the euvolemia, and the hypervolemia. So this is where your third test comes in, which is your urine sodium, which Mohammed had mentioned. And that's where you kind of now, so you have taken a chunk out, right? When you check your urine osmolality, now you have to look at you have to examine your patient, very important, and your urine sodium. Now, in real clinical setting, there's always an overlap. Okay, you can never have like a clear-cut euvolemic patient presenting with a urine sodium. No, it's never going to be like that. You might have a patient who looks volume overloaded, but this urine sodium is like all over the place. But we're going to leave those real life patients out, and we're just going to focus on what you might be asked in step 1 and step 2, and kind of go by the book here. So again, so we talked about hypovolemia, right? And so now you're going to check at your urine sodium. And now urine sodium is what? Urine sodium is again reflecting what your kidney is trying to do. What does your kidney really want to do at this point? You have low sodium in your body. Naturally, your kidney wants to hold on to every drop of sodium, every little particle or solute of sodium, right? And it wants to like conserve it. Your body needs that sodium. And that's really what's happening. So when you look at a urine sodium, which is less than 10 MEQ, and this is an arbitrary cutoff, but you're seeing a low urine sodium, right? What is your kidney doing? Your kidney is holding on to that sodium. And so that's really what you're going to see like in these cases, right? Diarrhea, vomiting, sweat, burns, trauma, any of these cases, you're going to see this happening. But anytime you see a higher urine sodium, like your patient has a low sodium and your kidneys are losing sodium. So what's going on? The problem is with the kidneys. So now your kidney is the problem. And so anytime you have these patients, so that's why these are called renal losses. So anytime your patients are on diuretics, right? Medications to lose water. Anytime you have cerebral salt wasting syndrome, which is another syndrome we'll touch base hopefully at some other point. But anytime you're seeing urine sodium on the higher side, problem is with your kidneys. And these patients are, and also remember, these are the dry patients. These are your hypovolemic patients, right? They're looking dry to you, you know, physically on exam wise, you know, their skin is like, you know, their body, you can tell that they're on the low volume side. And then you check their urine sodium, which tells you apart as to what's causing it. Is it the kidney, which is the problem, or anything in your body where they're losing it? And then comes your euvolemic patient, right? Patients who do not appear to have low volumes or higher volumes. And that's where your ADH comes in, and syndrome of an inappropriate ADH release. And the most common thing which actually kind of resets is drugs. I cannot tell you how many medications our patients are on, and they can cause patients to have SIADH. Any even simple things like pneumonias can do that. Any pulmonary issues can do that. If you have COPD, bad COPDs can do that. Malignancies, cancers can do that. So there's so many triggers for ADH, you know, that it's actually mind-boggling. So in these patients, what are you going to see? Remember, there's a lot of ADH sitting there, and your acroporins are sitting there. And what's ADH doing? It's absorbing more water as compared to your as compared to your salt, right? It's absorbing a lot of water. So your urine is going to have high sodium. Your sodium is going to be high. Remember, your osmolarity is high, your sodium is high, and your patient's euvolemic. Boom, boom, boom. ADH, SIADH. And then the last, and I guess I feel like this is like the easiest one, because even when you're examining these patients, you know that they're fluid overloaded. They have pedal edema, they have crackles, they could have anasarca, they have like ascites. They have all these signs of fluid overload, and now their sodium is low, right? And what's going on? Again, it's pretty straightforward. So your urine sodium, and it's pretty straightforward because, again, it's pretty much goes exactly how we talked about in hypovolemic patients, is that if your urine sodium is less, like despite all of that fluid, your kidneys are working hard to save every drop of that sodium in that urine, right? So this can happen in heart failure, cirrhosis, some sort of nephrotic syndromes. And if your urine sodium is high, right, the problem is the kidneys. Your kidneys are not able to hold on to that sodium or that salt. The tubules are being damaged, your nephrons are damaged, they have kidney disease in them, and so they're losing that sodium. So this chart right here is so important, so important. If you guys can remember this part and kind of you know, just remember the sequence of the testing and how it's done, and how that can determine the cause of hyponatremia, and why it's obviously important to determine the cause of hyponatremia is that's how you treat it, right? And so so I think this is again pretty much the same slide where I'm going over all the different causes and different different types of hyponatremia. All right, so with that, we conclude the talk. I am not going into management today because I felt like it would be too much information for one day. I guess I want you to remember this much of hyponatremia first, and then management could obviously eventually come in at some point. And I do have some Q&A for you all now. And feel free to type in the chat, and let's go ahead and do some few questions, and then I will take more questions once we are done with this little Q&A. So here's your first question, and they're pretty straightforward, trust me. A patient has a sodium level of 123 and presents with confusion. The doctor diagnoses the patient with syndrome of inappropriate antidiuretic hormone secretion. Which type of hyponatremia is this? A, hypervolemic, B, euvolemic, C, hypervolemic, D, antivolemic. Well, I didn't even read that option. C, hypervolemic. What else? Is that all? The rest of you guys are deciding not to participate? B, euvolemic. That's all? No more guesses? Okay, well, yes, that is the answer, you guys. It is B. Muhammad, remember we talked about ADH? Now, syndrome of inappropriate. Now, I know why you're confusing this. You're confusing this because you're thinking ADH is sitting there and it's acting like congestive heart failure. So it is ADH, so a pure ADH, a pure ADH will actually behave euvolemic. That's the take home. If it's complicated by something else like congestive heart failure, cirrhosis, and all those things, that's when you see the volume. A pure ADH just acts euvolemic. Okay, question number 2. A patient has a sodium level of 119. Which of the following is not related to this finding? Oversecretion of ADH, low salt diet, inadequate water intake, and hypotonic fluid infusion. I will let you guys sit and think about it and then answer my questions. Anybody who wants to take a guess on this one? Okay, so let's D, hypotonic fluid infusion. Okay, good try, Mohammed. Who else? Amna? Freddie? Okay, you guys want to pass on this one? Okay, okay, so we have a sodium of 119, right, which is low. What is not related is the question. So oversecretion of ADH, we all know, can cause hyponatremia. A low soft diet can cause hyponatremia. Hypotonic fluid infusion. So I think that was a tricky one. You cannot see the slide for question number 2. Can you guys see it now? I kind of backed up. Yes, okay, we'll just stick to this format then. Okay, so I don't blame you for getting this one wrong, because I don't think I explained to you what hypotonic fluid infusion is. So hypotonic fluid is basically you're infusing a fluid bag. Remember normal saline, regular fluid, which is isotonic. Hypotonic is you have low salt and too much water. So that saline bag has half the concentration of sodium in it as a normal saline bag. So when you give hypotonic fluids, you're basically causing the patient's sodium to drop. So a hypotonic fluid infusion can cause hyponatremia. Low salt diet can cause hyponatremia. ADH water can cause hyponatremia. And the correct answer is C, inadequate water intake. If you're not drinking water, remember we talked about thirst mechanism. If you're not drinking water, what's going to happen? You're going to get dehydrated, and what's going to happen? Your sodium's going to rise. Remember, you're going to have less water and more sodium, or not more sodium. It's not a sodium problem, but because your water is less, your osmolality is going to be high and your serum sodium is going to look higher. So it's basically, the answer is inadequate water intake. That will not give you hyponatremia. Too much water intake, primary polydipsia, marathon runners, that can give you hyponatremia. All right, question number 3. Which patient below is at risk for experiencing hypovolemic hyponatremia? So who can develop hypovolemic hyponatremia? A patient with congestive heart failure, patient with cirrhosis of liver, a patient on IV saline at 250 cc per hour, and a patient with nasogastric tube suction experiencing diarrhea. Anyone? D. Correct. Yes, yes, yes. We're talking about low volume, right? So suctioning fluid from their gut, carrying diarrhea, you're just sucking the water out of that poor patient. So you are going to have hypovolemic hyponatremia in that case. All right, glad you guys are learning something today. All right, yeah, okay. One more question. A patient with heart failure presents with edema, hyponatremia, and a concentrated urine, right? Concentrated urine. Activity of which receptor is most likely to be contributing to the symptoms? And I will let you read the options. Oh, I don't have ABCs on this one. You guys can type out the answer. Which part? Anybody? We went over the nephron several times. Collecting duct. Yes, that is your answer. So it's your ADH acting in your collecting duct. And you want to say distal convoluted tubule. That's not the primary location for your ADH acting. They're basically trying to ask you, where does your ADH act? So remember, we went over the nephrons. So distal is above the collecting duct. It is your diluting segment, but your aquaporins are mostly in your collecting duct. All right, last question. What fraction of extracellular fluid is contained in the intravascular compartment? This is physiology, and I went over this. I don't have ABCs again on this one, so you guys have to give me the answer by typing it out. One-twelfth, that's an interesting option. What fraction of extracellular fluid is contained in your intravascular compartment? 1/3. Perfect. Yes. Good job, Mohammed. All right. With that, we conclude this session, but I am happy to take questions. Anybody who would like to come on the speaker, ask a question. I know this was too much information for some of you, but I hope you were able to learn and retain some of it. All right, so it looks like we have no questions. So you guys are pro hyponatremia now, right? All right. Okay. All right. So that's my concluding slide. And we're going to conclude with what we started off. Kidneys are smarter than the smartest brains. And this is a little meme I got off the internet because kidneys can look like a kid's knees. All right.
Thank you for your mentorship and teaching, Dr. Arif. I will be leading our Q&A session for some questions that we've received over this session here. So for the first question, it says, could you discuss the potential neurological complications of severe hyponatremia?
and how they are managed in clinical practice, especially in emergency situations.
Okay. So can you repeat the first part again, not the management?
Right, yeah, that's a long question. Could you discuss the potential neurological complications of severe hyponatremia?
Yeah. So I think I briefly touched that during my talk, right? So again, if it's acute hyponatremia and there's like a quick drop, you're going to have osmotically driven fluid shifting into your brain cells, causing that rapid swelling. And your patients are very symptomatic. It can start from nausea, vomiting, to like confusion and really altered mental status. And you can have brainstem herniation, and you can go into coma, you can go into respiratory arrest depending on how severe the brain edema is. So that acute drop can do that. And when it comes to, so that can be, and if it's chronic, if it's like slowly sitting there, you're going to have such milder symptoms, like, you know, your gait is like you're wobbly, or you're just having some forgetfulness, and so on and so forth. Management wise, again, when it's acute, you have to acutely treat it as opposed to chronic. So in acute management, what you do is you want to, depending on how low the serum sodium is, if it's low, like so sodium is down to 110, you want to first give like a little bit of a hypertonic saline to quickly bring that sodium to a little bit of a safer level, like 115, 116, or 118, depending on where you started off, because remember we talked about that low sodium has increased risk of cerebral edema. And once you bring it on a little bit of a safer range, and then you have to gradually increase it. So by gradually increasing it, and you normally use normal saline for the most part for these kind of drops. But again, if it's like a CHF patient or a cirrhotic patient, you're not going to give them fluids, right? That's when your diuretics come in. That's when you want to get rid of that fluid. If there's a patient has ascites, you tap them. And so there are multiple things you can do, and then to treat that. And then just broadly speaking, and if you have ADH sitting there, so there's so many ways you can shut that ADH signal by kind of normalizing their volume status. But then there are also medications, the Vaptans, the tolvaptan, which you can kind of just quickly, give to the patient to kind of treat their sodium. So there are multiple ways of treating the hyponatremia depending on acute versus chronic, and depending on the type of hyponatremia. Okay.
Thank you for that question. So the second question that we received is, in cases of chronic hyponatremia, what are the long-term effects on the body's physiology?
So chronic hyponatremia, right? So again, body's physiology. I'm not getting the question. Is it are we trying to, whoever asked the question, are we trying to say what are the long-term effects on the body itself versus how physiologically is it happening?
Yeah, what are the long-term effects on the body's physiology? I guess the first part of what you.
So if your patients are having chronic hyponatremia, right? Some patients have something called as reset osmostat, where your brain has just set your osmolality. So instead of your usual, we talked about the range, right? 275 to 290. Instead of that, your brain has pretty much set it to like a lower osmolality. So you're going to be fine. You're going to have low sodium. Very rarely we see that, but we see patients who have low sodium, then they're doing fine. If you're seeing most of the times, like I said, when you're seeing chronic hyponatremias, depending on what range of that hyponatremia is, they're going to present with symptoms. Most common symptom is in chronic hyponatremia is, again, just weakness, lethargy, tiredness, and their body's physiology is gonna, present with something like there are patients who actually come in with high blood pressure, and then I check their sodium and it's actually low. So the body's reacting to it in a different form and way, as opposed to coming in with confusion and things like that. So again, low sodium has to be treated, needs to be treated. It's the most common electrolyte abnormality in the hospitalized setting. So you will see patients coming in anytime it's below 131, 130. Most of these patients need to get admitted to the hospital to get treated.
Okay, thank you for the insightful answer. So the third question we received is, can you discuss the challenges in managing hyponatremia in elderly patients, given their unique physiological changes and potential interactions with medications that they may be taking?
Yes, very good question. So I think the first step in treating hyponatremia, and especially our elderly patients, because as they grow older, their medication list is only piling up, is to start excluding the medications which are causing. Remember, we talked about ADH being caused by so many medications. The most common one are your SSRIs. And your SSRIs can actually, most of your patients are on this by that age, just as a part and parcel of the package they get from their PCP to medications they need to be on. So it's eliminating all the drugs which can trigger ADH. And you would see they don't even need these medications for the most part. You know, stopping these medications is first part of the treatment. And then, like I said, the challenging thing, it's challenging to treat hyponatremia to begin with, regardless of if the patient's elderly or chronic or, younger or adults. And the challenge is to not correct your sodium too quickly, because if you are going to bring that sodium from 120 to 145 in 6 hours or 8 hours, if you do that, you are putting that patient, you are going to make the patient develop demyelinating syndrome, and obviously his entire life and its outcome is going to be ruined. So the goal is you have to check sodium, depending on how low it is, between every 2 to every 4 hours. So these patients get labs every 2 to every 4 hours, and you have to change your management. So if your sodium, you have to have a goal in like every 3 hours, I want the sodium to go from 120 to, let's say, 122 or 123 is my 3-hour goal. And so if it corrects too much, let's say it goes to 128, I need to reverse it. I need to bring that sodium back to 123. And then with my next check, I need to make sure it's again correcting slowly. So it's a lot of back and forth. You will spend a lot of nights staying up trying to fix the patient's sodium, and that's happened, and that's totally okay as long as you're doing the right thing for your patient.
Thank you for that answer as well. We have 2 more questions. So the next one is, in the context of your specialization in nephrology, are there any ongoing research or clinical trials related to hyponatremia that you would find particularly promising or interesting?
Honestly, the most recent one, which I had a chance to go over, was also, now I'm glad that a lot of clinicians are also getting to practice, is it's pretty, I want to say it's pretty intricate, and I don't know how am I going to explain to you guys. So we use this drug called Samska to block your aquaporins. Remember we talked about it, your tolvaptans, and you can actually practice. You can actually not give Samska and treat your ADH patients. So it's been an interesting physiological journey, and you use a combination of diuretics and saline in that case, so to block your loop of Henle, and you kind of try to create hypertonic saline for your patients. It was a promising study which was done, and now with most of us, so many of our IC clinicians apply that. I personally use that technique for my patients because unfortunately, tolvaptan is not covered by insurance. So you can put your patients and correct their sodiums when they're in the hospital, but when they leave, they're still stuck with that. Another interesting drug, which has come about in the last few years in management of sodium or hyponatremia, which is again especially for our ADH patients, is urea supplement. So you get little sachets of urea supplement in your pharmacies, and that's been another promising. Well, it tastes bad. So patients we have a compliance issues. But other than that, so those are some of the newer treatment modalities which I've come across regarding management of ADH-related hyponatremia.
Thank you for that. So the last question is, how do you manage your work-life balance?
Interesting. So it's hard. I have little kids. I have a baby at home. I have an 18-month-old. So and you always need support. You always need help. Grandparents, nannies, daycares. You need all of that. And then you can also work to choose how much you want to work. And I have 2 kids. So at this point in my life, I decided to go part-time. So I only practice part-time. And once I had my little one, I just wanted to be more present as a mom. And I do plan on going back full time actually next year, 2024. My kid will be almost 2, and so I will be in a better place to get back to working. So I guess I'm glad that somebody brought up this question, because it is important, especially in this day and age where and I've actually I made that decision. It was hard to go into that decision, but when I looked at my peers, my people who were, who had older and grown-up kids, and the only thing they said they looked back on and regretted was not being present for their kids when they could be, and now their kids are in universities and colleges, and they miss that time, and now they're older and they want to work less, but they have no kids at home. So I kind of took that advice and I decided to go part-time. And even though I go back full-time soon, I will hopefully have a less hectic work schedule. So it's going to be full-time with a lot more time off than I used to previously have. So hopefully it's going to work out. But yeah, very important to maintain that work-life balance, especially when you have young kids.
Makes so much sense. Thank you very much, Dr. Arif. Those were all the questions we had for today. If anyone could give a warm welcome to Dr. Arif in the chat box for her informative session. Thank you.
Thank you. I hope you guys learned something today.
Yes, definitely. Thank you, Dr. Arif. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And our next live session will be next Saturday, September 23rd at 10 a.m. Eastern Standard Time for an internal medicine session. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. And this concludes this week's shadowing. Thank you.